focusing on sustaining change and I'm going to share my reflections. I focused on sustaining a change more at a project level, but thinking about the organisation as well. Oh, gone too far. So using the clinical audit cycle or the model for improvement or another improvement tool, a key aspect is implementing change. I understood when undertaking a clinical audit cycle, it was important to re-audit and check for change. Otherwise, I couldn't call my project an audit. It was merely data collection. So I completed the cycle. On re-audited, there wasn't much improvement, and I was puzzled as to why the method that seemed so sensible wasn't having the effect I wanted. The project team had agreed lots of actions to be taken, and I'd checked in with them regularly, with those involved to ensure that the actions had been completed. Surely this would lead to improvements. Then I named the model for improvement, a light bulb moment. I could answer the first question, what are we trying to accomplish? I implement that new NICE guideline or standard. As second and third questions, how will we know that change is an improvement? And a change we make that will result in improvement harder. The model for improvement introduced me to the notion that I didn't know which actions were having an impact. I had the best intention of doing everything in our grasp to implement that new standard, improve X, Y, or Z, but which changes were working. I had that guidelines we're implementing were the right thing to do. That was the easy bit. What I couldn't answer was whether doing that specific action would lead to the intended outcome. Runs go hand in hand with the model for improvement and PD safety cycles. They're simple graphs that track measurements over time. That clinical audit, the credit method of 2 fixed data points did not enable me to understand the trend that was occurring in between the data collections. As illustrated here, it's possible that the change is or isn't associated with an improvement. And I've got so in the chart, you can see on the left-hand side what happened with 2 traditional clinical audits. You've got your data at initial data collection and your data collection afterwards. But there are 3 trends here. Some changes seen with improvement and sometimes not. Of achieving a sustaining improvement, you don't need to collect lots of data, but what I realised is that you do need some. Our measures, following the aim, what's the process measure, things that we think will lead to an improvement, and thinking of a balancing measure. So, for example, when we've been looking at hospital-acquired pneumonia in our trust, we looked at the prevalence of pneumonia, a process measure, raising the bed head by 30 degrees, and then a balancing measure, looking at whether we were going to have any unintended consequences, such as causing pressure ulcers. When using data, I need to remember that the goal is improvement, not the difference of a measurement system. Useful data, but not perfection. Integrating measurement into daily routine, little and often, that it wasn't too time-consuming, and that you can check in regularly with how things are going. Data real-time means you know how things are going, and when that's happening, you can react. Where possible, I started to introduce a change at a time to see whether the change was having an impact. This enabled me to see when that good idea turned out to be not so good. That day, I'd learned what not to do, and that's important too. By starting small, it didn't take a big amount of energy to see what worked for one patient, one way, or one ward, and it did. It could be rolled out further. Measure process and outcome would enable me to understand and articulate what was working or not working. This needs to be thought of in the planning stages of projects. Both framework and project approach we use at the Royal Berkshire encourage project teams to consider sustainability right at the start of projects. And in this, you'll see the template that we use here at the Royal Berkshire, and you can see that sustainability is really quite key to all our projects. Making sure we're engaging staff, aligning with goals and structures. We have the infrastructure, the credible evidence for making the change that we're wanting. We can be accountable, and we're continually monitoring progress. What's shocking is here that when a recent survey was done, that 55% of employers felt change management initiatives met initial objectives, but only a quarter felt gains were sustained over time. In this, you then have the improve approach that we use, and you can see here we've got sustainability featuring in our evaluation. But an important part of our projects, in addition to measurement, is return on investment. The organisation needs to be certain of value if it's to continue supporting projects. That testing for sustainability involves a lot of talking to people. Do people see the need for improvement? Are people committed to driving change? Do people have the confidence, ability and skills to carry out what is required? Yes, can be built into objectives and appraisals, can create new opportunities for learning, but people incentivised, do they see the benefit? People act in self-interest and they need to see what's for them. Build periods where you can step away to see if systems are embedded or rely on individual people enables you to sustainability. But be aware, there is danger in taking your eye off the ball. And get comfortable. Keep checking. Use questions displayed here that I've often used to ask about sustainability. I've learned not to be afraid at saying it as it is and asking direct questions. People be honest with their views. The negativity soon dissipates, and often it's much better to listen rather than talk. The point of learning for me was quite how important communication is. You never really can communicate enough. Messages can be spread through newsletters, champions, Twitter, providing visual prompts for people. For example, get porters wearing T-shirts, logos or consistent images across the documentation. Time creative thinking. Something that didn't come easily to me, but there are tools to help you with that. Improving quality, the website has some really good examples. For some benefits of what we're looking to make better, if I answer the question of why we're doing something, then what's the point? I'm always conscious of the need to justify why you need to make the change, not just for change's sake, and make it meaningful. Okay, we focus on the negatives, what hasn't worked, accident, complaint or claim. This is our opportunity to celebrate the good things, highlighting benefits, improved safety and improved working lives. Telling people to change isn't enough. You have the numbers and where changes have been successfully piloted, but I've learned that to have the most impact, you also need to make it personal. People need to connect with the story. Are improvements making people happy, both students and staff? Sustained change means continually identifying and addressing negative ruts. Patient leaders working together with staff help with experience, understanding the why. They help keep the energy and enthusiasm. Working in collaboration with patient leaders can make it feel different and help staff that it's going to be different this time. With a more focused approach and targeted interventions, we can work smarter. They're a key part of driving change. Face for negativity, don't ignore it, address it, get rid of it and move on, creating positive ways of working. Focusing on achievements helps keep up momentum. A little recognition goes a long way. A high is free of a grade 3 or 4 pressure ulcer, rising the most reduced length of stay, or completion of care bundles. Whatever method, focus on the achievements. 5 ways of sharing the load and spreading communications by developing networks. Use your champions. I'd like to think about the role of networks. It's really a fantastic way of getting support, shares and learning, and keeping energy going, sustaining us as individuals as is the work that we do within organisations. The National Quality Improvement and Clinical Audit Network brings together 15 regional clinical audit and effectiveness networks from across England, providing a voice for staff in these areas, work in health and social care organisations. NQICAN supports the development of regional networks, national clinical audit, as well as engaging influence and being a point of contact for key organisations such as HQIP. You can contact NQICAN via email, as here, and we're on Twitter at NQICAN. Regional clinical audit networks. Hopefully several of you are in your regional networks, but if not, please do get involved. There are 15 networks that you can see here, open to those working in clinical audit, aiming at improved care for NHS patients and all social care by organisations such as hospices. While regional network operates slightly differently, they cover similar topics such as clinical audit, effectiveness, quality improvement and governance. The networks bring together people to share good practice, provide peer support and influence contribute to the national quality agenda. We'll be having our website, NQICAN website will be launched at the HQIP conference, making it easier for people to get in contact. Summary, key to knowing what works and what is continuing to work. Vision is clear vision and purpose is imperative. Change will not happen without people, and relationships and behaviours are key. The organisational commitment, leadership and finance must be there if the project is going to be sustained. They need to be built in from the start. If together we can make change happen. Thank you for listening. Do you have any questions? Thank you for discussion.
Thank you so much. That was really great. We have a couple of questions. A quick one from Pauline, who says, you mentioned a website on the communication slide. That must have been a bit earlier. She wanted to know which website that was.
The NHS Improving Quality.
IQ.
Yes. Some of the resources are still on the old. So it was the NHS Institute for Innovation and Improvement that organisations now ceased. And we've got a new organisation called NHS Improving Quality. On the old website, you can still access a lot of the tools, but believe that NHS Improving Quality are trying to put all of the tools up on their website. But there's some simple ways of just helping people think creatively, and it's something that certainly hasn't come naturally to me. So they've been really useful tools.
That's great. Oh, thanks. Oh, Sam has just been able to put the website up there now.
Brilliant.
You can see it on the side. That's great. I've got another question. You talk about measuring little and often.
Yeah.
It's an ideal, tell me about an ideal benchmark about how regularly that is actually.
It depends what change you're wanting to introduce. I mean, it may be, depending if you're be literally sort of once a day that you go and look at a measure, or once a week, but certainly little and often, I think you'd be checking in on a weekly basis. But it enables you, so I'm not talking about huge numbers. It may well be that you're only collecting data on a handful, so sort of half a dozen patients. You're just really checking in to see whether the change you're introducing is actually having an impact or not. So we focus our work, rather than thinking when we do an action plan, let's do 50 things that we all think is going to make an improvement, that you actually do make a change at a time and see whether that change is having an impact. So you can do more of the things that have the impact and less of the things that don't. But
sometimes
huge amounts of data.
Because that you can do a snapshot audit, a rapid audit, isn't it?
Absolutely.
Yes,
and when you're doing your clinical audit, identify where you're meeting standards or not meeting standards, and pick areas that where you're not meeting your standards, and then do your improvement activities and your measurements around them. So you're not continuing to measure every single audit standard. You're focusing on where you're driving the improvements.
I have another question. I was really pleased to see you had a slide about having some patient leaders. And Jenny has also a question here saying, how easy have you found it to get patients involved, and what were the main barriers, and how do you break down those barriers?
Okay, so we've started, in the last year, we've started recruiting patient leaders, which is at the Royal Berkshire. This is a program, a 7-day modular program for patient leaders. It's a voluntary role. We do take patient leaders through quite a rigorous recruitment process, so we can make sure that their values and behaviours are consistent with what we're trying to achieve. We're looking for people who are able to work to support the strategic direction of the organisation and truly work in collaboration with us. So putting challenge, but in a healthy way, and really can convey the patient's point of view. So being that sort of conduit between staff and managers, clinicians, and patients. So bringing that voice into the room, but they're not afraid to articulate. In terms of recruiting, we advertise on NHS Jobs. So that's somewhere that not naturally patients or volunteers would necessarily come up. So we've got a series of posters that we've shared with our local GP practices, big organisations. So far we've managed to find that we've recruited 12 patient leaders so far this year and are looking to continue that. And it's really quite noticeable, the difference where you're focusing on recruiting the right patient leaders, the energy and enthusiasm and skills that they can bring. So we've got people who used to be head teachers, and people who've worked in social services, all sorts of organisations, financial organisations, business consultants, and also all ages. We've got some youngsters in there as well, so people who are going off to medical school. Really, actually, surprisingly, have well at recruiting those individuals.
And I think also to get patients who have got the real life experience as well, especially when it's about a particular project and they've got relevant experience of that area. I think you can get patient stories to really champion a project.
Actually, I think bringing that human, we all connect with stories, and so if you actually got a patient in front of you who can say how they would like to be treated. So, for example, we're now kicking off the Hello, My Name Is campaign. That was driven by a patient leader who had a poor experience of not knowing staff's names. So that leader has really been the driving force, has gone to talk to our board, get them on board, and really been a key driver. And it's so much more powerful when you've got staff being inspired by a real story.
We've got Dr. Kate Granger coming to our conference actually next week, so she's got a presentation, I think it's Monday afternoon. Really great to hear from her there at the conference. Kat, another question, coming in now the questions. Do you encounter any barriers when, we just said that one, where are we going? I don't know. Would you say networks are good places for staff new to clinical audit to learn the tricks of the trade?
Absolutely, yes, absolutely. We have HQIP yourselves at pretty much every network meeting. What we've learned at the networks is that training needs to be a key part in order to get people to attend. So we do build in, each regional network has their own chair and they operate slightly differently. but a key aspect of all of the regional networks is that training. And it's an opportunity. Working in clinical audit and quality improvement can be quite isolating. So it's a really good opportunity for you to meet others that are in similar situations, might have come across similar problems, but also learn new skills.
I think our patient conversation earlier has raised another couple of questions, Kat. Hancock has asked about the good representation in patient groups, but I think you said that you do get some youngsters, some medical students involved, don't you?
Yeah, we're quite mindful of making sure that the people that we recruit for patient leaders do represent the society that we serve. I know question about having people with experience of particular diseases or conditions, and sometimes people younger might not necessarily have had that experience directly, which is why we've not restricted patient leaders to those that have accessed our services directly. We're all going to come into contact with the NHS at some point, and we all know how we'd like to be treated. So we don't require that people have actually accessed our services. Most of the users that we've got have had a relative or somebody in contact with the hospital, but it's not an essential requirement. And I think that was quite key for us that we didn't put that barrier in place.
Thanks. And following on from that, have you had any issues with regard to information governance when you get patients involved?
Patients are taken through the same, even though they're volunteers, they're taken through the same process, recruitment process. So they do all of the same mandatory training that our staff would be, and they are required to do same contracts in terms of information governance. So we haven't had that problem. I think partly because we're focusing on getting right people and then through a rigorous recruit process, a training program in place that, as I said, it's a 7-day modular program that looks at leadership, quality and the way of working in the organisation, that we haven't found that to be a problem.
That also answers Amy's question where she was asking how do you train the patients in clinical audit, but you've just said so it's a week-long modular program.
So patient leaders, given it's a 7-day modular program that focuses a lot on leadership in there as well. So thinking about the impact that they can have themselves and working with others. And as part of that, we have a day talking about quality, the concepts of quality, quality assurance, quality improvement. You'll understand problems. It's at quite a high level, and we found it's quite at that stage when they're new into the organisation. It's too much for them to learn the detail about clinical audit methodologies, the model for improvement. So we then invite them back to do 2 days of half training, quality improvement methods. Later in there, once they've got to know the organisation a bit, some of our patient leaders have been working with the NHS, really understand it and can go straight in and do that training. Some of them want to spend a little bit of time getting to know the organisation before they start leading their own quality improvement projects. And certainly that's a place that we'd like to get to, that we don't feel that patient leaders can really actively contribute and work with us in collaboration. It's okay for us to be, for them to be leading projects and us working together. So we're all valid members of the team.
When you do the training, do you explain the model for improvement, and is it the same way you explain it to clinicians as well?
We do go through the model for improvement, yes. So that patient leaders are in many ways advocates of quality for us. They can get it into different parts of the organisation. Essentially, they are championing the work that we're doing in terms of quality improvement. So yes, they do learn the model for improvement, the importance of measurement, and that if you can't demonstrate your outcomes and articulate what change is having effect, that putting that question in. So I have known our patient leaders to say, why are you not measuring that? How do you know that's an improvement if you've got no measurement? So absolutely, yes, we do give them the same training that goes to clinicians, goes to our patient leaders.
That helps engage people in the idea of audit and quality improvement.
Absolutely, yes. Yeah. What we're finding is that generally doing more time data collection, that continuous data collection that's a bit more dynamic, is really energising and engaging people, because they can see change happening in front of them and can see the impact of their changes. So moving away from, I'm a great supporter of clinical audit, but it's moving away from traditional methods of clinical audit, where you're sitting at a desk in a sort of room somewhere, collecting a load of data from notes, and then develop an action plan, coming back later and re-auditing from notes. Actually can make it more dynamic, getting out there, talking to people, seeing how change is having an impact, and we can make changes in a more timely way, and that is engaging staff and patients more.
Brilliant. Thank you, Kat. Final question about the networks. Are they open to primary, tertiary care or private organisations as well?
Essentially, if staff are providing, working in clinical audit and quality improvement, they are providing care to social care, yes, so whether that's primary care, tertiary care, yes, absolutely, that's what the networks are there for. Actually, we're looking at quality improvement and clinical audit.
Are they private organisations as well?
So we have got some hospices and private organisations in some of the regional networks. We do voluntary organisations. So there's a real range. What we need to remember is the sort of purpose of why we're there, and that's to improve and learning around clinical audit and quality improvement. So if people have that as their goal, then they can come along the network.
Thank you so much. It was a great presentation today, and I think we've had a really good week of it all, actually, and I'm pleased to end on a positive note and talking about patient leaders and things like that. I think it's brilliant. Tonight we'll be continuing the discussion on Twitter between 6:30 and 7, and will you be able to join us?
I will there, yeah.
Brilliant. So if you have any more questions for Kat, you can put them on Twitter, #ClinicalAudit. We've had a really good week, and it's been brilliant to see the photos of other people having their clinical audit break on Tuesday and Wednesday this week. Well, our conference is coming up on the 3rd and 4th of November. You can see highlights. We'll be tweeting all the highlights, and keep an eye on our website. Thanks again. It's been brilliant today. And we'll see you in the 30 to 7 o'clock clinical audit, #ClinicalAudit Twitter chat. Okay.
Thank you.